Good morning. So last time we did the practical work regarding how to proceed with the bronchoscopy, how to do the airway mapping with the help of the bronchoscope. So that was the practical session last time. So we'll continue with the theoretical session today. So we'll have several sessions regarding this concept of how to map and also correlate with the CT findings. So, I will not be going in detail regarding the segmental anatomy. I think Dr. Sovlan and Sandeep should be very familiar with this anatomy. So that is in the supine position. The lungs look like this as shown in the left side of the picture. In the right side is the bronchial division. It's a very complex division. I think God has created liver and lung almost similar way. But lung is looks like more complicated. So what we should know for Sovlan that we can remember like mimic. So it's not very essential. You can just remember in the right side we have the 10 segments. In the left side 9 or 8 according to the classification which you are using. So for the right side, upper lobe, middle lobe, lower lobe is the basic things. The segmental anatomy you must remember everything by heart. It means you shouldn't be confused with the segmental anatomy at least. So this is the same for the left side also. There is the terminology that ACI Alps like A for apico-posterior, S for superior, etc. So we must remember these stuff. The complexity arises now. So this is the picture. I believe that every one of us should know about regarding this picture. So you can visualize how difficult it is. So this is the trachea going the right main bronchus. And if you remember last time we showed this the upper lobe that divides into 3 segmental bronchi that have been placed in the different colors. Color coding has different, like B1, B2, B3, etc. So this is the supine position. We must learn how to tilt it in the lateral position or the coronal image, sagittal image, etc. while you're doing the CT scan film also. So the principal nomenclature, we should remember that the lung has been divided. We go from the cranial side to caudal side. So cranial means superior, caudal means inferior. Then the second, if nothing happens like the branching pattern, it's not like that, then we consider the second one, that is the posterior anterior. And the last one is the lateral and medial. So these 3 points we must remember always. That's why we remember this. I will talk in detail later on. And the same way the generation, like 0 means the main bronchus, 1 means generation 1 means the lower bronchial division, like upper lobe, middle lobe, lower lobe is the generation 1. Generation 2 means the segmental bronchial, like in the right upper lobe we have the B1, B2, B3, etc. In the subsegmental, that is generation 3, that is the A, B, C. It means like, let's take the B1 bronchus, upper lower bronchus, apical bronchus, that has got 2 subsegments, B1A and B1B. So then, but if we take, for example, this one only, this is the right main bronchus. So this is the 0 level, right? The level 1, generation 1 is, or this is also 0 level. Level generation 1 is the lower bronchi, like upper lobe bronchi. This is generation 1. Then it divides into the 3 segmental bronchi, right? So this is the B1, this is the B2, and this is the B3. So this is the generation 2. Now it can be further divided, like this one, it comes to the B1A and B1B. That is the 3rd generation division. And this may be further divided also, like B1AI, a woman. And similarly, B1AII, so this is the 4th division, etc. This will go further, that's why alpha, beta, gamma, etc. So this kind of divisions happen. So this is how the Japanese have, there was a consensus by Japanese Society of Bronchology. They have defined this kind of divisions up to sub-segmental. It may go further in X, Y, Z also of 6th generation of divisions. So I think that is not of much importance except besides the anatomical importance. So as you show here, as the same thing has been depicted in this picture that just I talked about it. So this is the 0, this is the generation 1, this is the generation 2 because of the segmental bronchi. Then comes into the subsegment generation 3, then generation 4, generation 5, etc. So where does comes the, this picture is also very important for us to remember last time how we proceeded with the bronchoscopy. So patient is lying supine. So therefore this is the head end of the patient, cranial. This is the cord and the foot end of the patient is there. And we proceed from the trachea. Here we go inside. So let's suppose we are going to the right side. So we turn our body and also the shaft of the scope to the right side here. Then the first structure that comes out of the right upper lobe bronchus, right? Like we did last time. In the right upper lobe bronchus we go, then we'll visualize three segmental bronchi. So it has been depicted here. Like this is the B1, B2, and B3. So we must memorize it in our mind. And also we must be able to draw the illustration like this. So whenever you see the picture in the bronchoscope, we have to correlate with the CT film also. So these structures we must be able to define in the CT scan. So now I'm trying to learn those stuff in the 2D CT scan, because in the Western society, in the developed Asian society, they do with the 3D reconstructions, since we don't have that facility as of now. So I think this is a good chance to learn the bronchoscopy image and translate into the 2-dimensional CT scan film that in the next sessions we can discuss about. But this picture, we went into the right upper lobe. So we must remember this is the B1, this is the B2 and B3, and B1 has been divided in B1A, B1B as shown in this picture. B2 also in B2A, B2B, and B3 also in B3A and B3B. Then you go downwards, then you have the middle of bronchus, which goes anteriorly towards the medial aspect, and that has got the lateral segmental and the medial shown here. And similarly, B4A, B4B, B4, B5A, B5B. Then we go to the lower lobe bronchus, then we turn rapidly to the right side, and we can visualize this structure. Is it clear? Sandeep, any question in this regard? Because this picture is very important. I found this picture in one of the books. I found it very catchy. So we must be able to recall this image. Then if you recall this image, then during bronchoscopy, it will be easier for you to identify which segmental bronchus is which one. And we can also try to find in the 2-dimensional CT scan the similar picture, and we can find where is the subsegmental bronchus or where is the segmental bronchus to be identified. So now, just in brief, today I will be talking, because it's a whole chapter, maybe 3-4 chapters that we can discuss how to correlate this bronchoscopy finding with the CT scan finding in the 2D. Just in general, we take the pictures axial slice at different level. The one of the levels is just above at the level of the arch of the aorta. This is the arch of the aorta. So this is the right side, this is the left side. So what we see in the CT scan, this is the anterior segment, S1. This is the apical segment, this is the S3, this is the S1, and the posterior is this is the S2 segment. So यसरी चाहिँ हामीले define चाहिँ CT scan मा image मा at the level of the arch of aorta. In the left side we have got the apico-posterior and the anterior only. कसरी anterior र apico-posterior define गर्ने? Because this is the sternum lying anterior. Therefore this is the anterior part anyway. And this will be the posterior to the bottom towards the vertebral body. That will be the posterior part, right? So this is the apico-posterior segment. Clear? So how will you define? So for this, not only the axial CT scan is required. You need to have the coronal view also. You need to have the sagittal view also. But the axial one is the typical one, the reference one that we have to deal with. In the same way, in the right side also we can define. Next we go down. If we go down at the different level, we can identify different segmental branches. I will talk in a moment later. So let's suppose this is at the level of the aortic arch that I just talked about. It's the same thing. This is the anterior and apico-posterior in the left side. This is the anterior, this is the apical and posterior in the right side. So this is at the level of the aortic arch. If you move forward in the level of the at the level of the left pulmonary artery, the different structure, different segmental branches will be seen. At the left pulmonary artery, we can see only anterior and apico-posterior. A part of the lower lobe superior, S6 will be seen here also. If you go to the right side, then also we can see the anterior branch, the apical branch, the posterior and superior, the S6 of the lower lobe will be appearing. Similarly, at the level of the right pulmonary artery, so this is the right pulmonary artery, this one. So you can see the anterior and this is the medial. It is of the middle lobe. Middle lobe will appear because we are moving down from cranial side to the caudal side. So these things we can visualize in the CT scan. If you go to the ventricular level, definitely the basal segments will be seen in both sides. In the left side and right side shown in this picture. Is it clear? CT scan we have to identify at which level you are looking at. At a particular level, you can visualize the upper lobe. At the next level, you will visualize the middle lobe. At the next level, you will visualize the lower lobes. So that depends upon the level of the CT image, etc. So let's suppose one of the examples in the CT scan. Here we can see it at the level of the arch of aorta. I showed that this is the major fissure, right? Oblique fissure. in the right side. This is the oblique fissure in the left side. So in this picture, there is a trachea. So we can see this one, which will divide. This is the anterior part in the right side, right? This is the posterior part in the right side. This is the apical part. So in this way, you can define. This is the S3 segment. This is the S1 segment. This is the S2 segment, right? In the left side, this is the along the major fissure towards the vertebra. This is the apico-posterior S1 plus 2. This is the S3, right? And just appearing just beneath the major fissure, oblique fissure, with the lower lobe. So this will be the S6 segment in the right side, S6 segment in the left side. This is how we can define the CT scan. Similarly, if we go beneath at the level of the pulmonary artery or the carina, we can visualize that this is the oblique fissures. So it's the posterior segment of the right upper lobe. This is the anterior segment. And meanwhile, we can visualize the bronchus also. This is the right main bronchus. This is the left main bronchus. From right, you can see the branch arising from here. So we must remember in the CT scan what happens. If we take the coaxial CT scan, which is structures are moving vertically down, that will see round in the CT film. Vertically down on the bronchus, so that will see visualize rounded structure. So therefore, trachea and the main bronchi are seen rounded in the CT film. Whereas if we look at the interior segment bronchus and the posterior segment bronchus, they will appear horizontal or oblique because they are lying parallel to the axial CT films. Therefore, they will not appear rounded, but they will appear horizontal or oblique. But now the question comes, where is the B1 then? Okay, Sandeep, why we do not visualize the B1 in this particular film? There should be three segmental bronchus. There's the upper lobe bronchus is seen very clearly. B3 is being seen here. B2 is being seen here. Then where is the B1?
Segment above to that.
That's one thing. The second, because it's rounded, B1 is cut because it moves upwards vertically. That will appear rounded. So that is masked by this one. इसको भित्र चाहिँ देख्नु जस्तो यहाँनिर छ नि उसको भित्र एउटा गोलो देखिनु पर्ने हो जो कि यसमा मास्क हो कि हामीले देखेन यसमा B3 B2 देखि त्यो गोलो भएको कारणले हामी देखेन सुपर इम्पोज भयो तर एक लेभल माथि हायर गएको भए यसमा गोलो चाहिँ यही फिल्ममा कुनै यो लेभलमा गोलो देखिन्थ्यो र that will be B1. Therefore, in this particular CT film, we do not visualize the B1, right? Depending upon the which distribution of the image is there. Similarly, it's the right pulmonary arterial level. It has been shown in this picture. And definitely, if we move downwards, then lower lobes will be appearing. Like is shown in this picture at the level of the ventricles. Ventricle level, this is the oblique fissure. This is also the oblique fissure. The lingular in the left side. And the middle lobe, sir. And the posterior segment of the right upper lobe, sir. And this in the right side, for example, this is the medial basal segment. This is the anterior basal segment. This is the lateral basal segment and the posterior basal segment. And so in this way, you can define which segments are there. Your picture is very clearly seen. And there are these accessory fissures also. This is the oblique fissure. This is the horizontal fissure. You say accessory superior fissure, sir, because this is the S6 segment of the right lower lobe. And this is the basal segments of the right lower lobe. This should be the middle lobe because it is bounded by the horizontal fissure and the oblique fissure. And clear, sir, Saudan? It's clear? So this is defined. So this image has been flipped. When I'm deciding to CT image in the right side should be seen in the left side, basically while doing the bronchoscopy. Bronchoscopy, I'm supine position. Right is the right of the patient, but in the CT scan is the reverse way. Therefore, you image reverse. यो चाहिँ राइट साइड यो लेफ्ट हैन यो त राइट ठिकै हो अर्को इमेजमा फ्लिप गर्न सक्छौ कुनै पनि सफ्टवेयरमा रेडियन्ट भ्युअर होस् जेमा पनि फ्लिप गर्ने अप्सन छ इफ एनी कन्फ्युजन हामीले ब्रोन्कोस्कोपीसँग कोरिलेट गर्न खोजेछ हामी जस्ट इमेज फ्लिप गर्दियौ राइटलाई लेफ्ट बनाइदियो लेफ्टलाई राइट बनाइदियो ठ्याक्कै ब्रोन्कोस्कोपी इमेजसँग कोइन्साइड गर्छ ओके त्यसैले चाहिँ हामीले गर्न मिल्यो सो लाइक आई टोल्ड यु लाइक फ्लिपिङ अफ द इमेज वी शुड बी फ्यामिलियर विथ दिस हामीले ट्र्याकियामा गयो ब्रोन्कोस्कोपी इज हियर देन वी गो here and for the right upper lobe bronchus what we do we turn the bronchoscope clockwise okay remember right side we're going to move and we turn the bronchoscope clockwise in order to go to the right upper lobe bronchus it's almost 90-degree clockwise CT scan time 90-degree clockwise so if you want to similar image in the CT film first we think what we should do I'm the right but in the CT film I'm right so what we did first we flipped the image यो बेसिक थिङ हो जो कि हामीले सुरुमा जान्नको लागि हैन फ्लिप यसरी हुनुपर्ने ठाउँमा अब फ्लिप गरेर हामीले यसलाई राइट बनायो यो राइट भयो ब्रोन्कोस्कोपी पनि राइट भयो हो राइट सो यो जस्ट बेसिक नलेज हो कि हामीले यो जान्न हामीले माइन्डमै सेटअप गराएको छ भने यति फ्लिपिङ गर्न जरुरी छैन इफ हामीले क्वेसन भइरहेछ कन्फ्युज भइरहेछ भने ब्रोन्कोस्कोपीको इमेजसँग ठ्याक्कै मिल्दोजुल्दो बनाउनलाई what we did we flipped the image here initially the image should be like this when the radiologist provides us but in the software we flip the image so now the right side is this one and this one so and the next thing is to properly visualize the segmental bronchi in the axial CT. We have rotated our scope clockwise 90 degree. Upper lobe bronchus. So in the CT scan, we have to rotate the CT scan counterclockwise 90 degree so that the similar pictures that we visualize in the bronchoscope, we can visualize in the CT. Is it clear? You know, I mean, bronchoscope clockwise. अब त्यसलाई सिटी इमेजसँग कोरिलेट गर्न सिटीलाई के गर्नु काउन्टर क्लकवाइज 90 डिग्री फ्लिप गर्नु पर्यो के त्यही यो पिक्चरमा यही देखाएको छ कि एक्चुअली इट शुड बी लाइक दिस नाउ वी काउन्टर क्लकवाइज रोटेट सो दैट इट अपीयर लाइक दिस हैन त्यो हुँदाखेरि यो जे यसमा राइट अपर लोब ब्रोन्कसमा देखिन्छ तिम्रो ब्रोन्कोस्कोपी इमेज विल बी सिमिलर लाइक इन दिस पिक्चर सो यो चाहिँ बेसिक सो वी डोन्ट नीड टु गो इन डिटेल बट फर द बिगिनिङ इन order to avoid the confusion we can use this pictorial diagram also flipping the image. Now we have been defined in the CT scan, also in the bronchoscopy. Sometimes the bronchoscopy we see going parallel. It's very easier to introduce the bronchoscope because it's in the horizontal or oblique direction. It may be difficult if it's shooting up in the vertical direction. Bronchoscopy tilt garna garo huncha. B1 bronchoscope bhitra pugna garo huncha rather than in B3, B2. Okay. त्यो हुँदाखेरि there are the vertical pattern of orientation like B1, B2 is simpler example. When we do the bronchoscope, it will be difficult to introduce inside it because it's shooting up vertically. You know? And in those things, in the CT scan, the structures will be seen rounded. So that's why I showed you the B1 image, it's round, okay? This is the B1. Usko segmental B1A, B1B, this is the vertical orientation of the bronchial tree. Sometimes what happens, horizontal pattern. Manale, isko jun bronchus this is also horizontal. Usko division pani horizontal sir. When two divisions will be seen in the horizontal direction. This is the normal image. This is the counterclockwise by 90 degree rotation of the CT image. And your vertebra here, sir. Isko vertebra here flip karasa image, like rotate karasa counterclockwise. So in this image, what we see, you see upper lobe, right? Isko say B3, B2 say eta aunu parne hamle थाहा छैन. यो B3A को भनेको lateral हो, B3B भनेको medial हो. थाहा छ सबसेगमेन्टल सौजनले यादै गर्नुपर्छ सबै कुरो. किताबमा जाने नमोरीको बुक छ अथवा हामीले पीडीएफ प्रोवाइड गर्दैछौं लियन चेङको बुक छ त्यसमा चाहिँ यसको सबसेगमेन्टल डिभिजन छ ताकि सीटी स्क्यान रिड गर्दा इन्टरप्रिटेट गर्दाखेरि हामी थाहा हुन्छ. Why it is important? Because if some lesions is located here, how will you identify bronchoscopic adjustment? Exactly where is the lesion located? It's very important for the surgeons. I mean, anatomical location jana zaruri cha. So here we can see very clearly seen B2A rising here somewhere. B3 is this one, so B3A, B3B. So these are the two horizontal branches, and we'll be able to draw the image like here. Like B1 यहाँ हो, bronchoscopy त्यस्तै देखिन्छ. B2 यहाँ हो, र B3 को A को यो हो, B3 B को. And so we must be able to draw the image in our mind at least. You don't need to put the diagrams, but we must remember. त्यस्तै going further. मैले के भनेको थिएँ एक ठाउँमा भने कि सुरुमा मैले गर्दाखेरि के भनेको थिएँ we first direction के हुन्छ up to the segmental bronchus it's not needed. Beyond that कुनै पनि हाम्रो आयो भने सबभन्दा superior र inferior वा cranial र caudal हामी हुन्छ हैन. So यसलाई जुन आउँछ जस्तो एक्जाम्पल लिनु BA sorry B1 को A र B को अब A को पनि दुईटा ब्रान्च हुन्छ AI र AII हामी कसरी डाइरेक्सन युज गर्ने जो ब्रान्च सुपिरियर पहिला आउँछ त्यसलाई आई गर्ने त्यसको ब्रान्च रहेछ भने जस्तो कि यसको एउटा सुपिरियर छ यसरी इन्फिरियर छ भने यो B3A छ भने यो B3AI हो किनभने सुपिरियर हो क्राइनियल साइडमा यो तल गयो भने B3AII हो इन्फिरियर. If this is missing superior inferior missing then we come to the next one
lateral medial
medial र posterior interior. त्यसमा posterior interior ग्राउन्डमा चाहिँ कुन छ जुन चाहिँ त्यसलाई posteriorलाई आई राख्ने इन्टेरियरलाई आई राख्ने त्यो पनि मिसिङ छ. अर्को डिरेक्सन सबै सधैँभरि यही डिरेक्सनमा त हुँदैन. कसैको प्याटर्न होरिजोन्टल हुन्छ कसैको प्याटर्न होरिजोन्टल भर्टिकल हुन्छ कसैको होरिजोन्टल ओब्लिक हुन्छ डिपेन्ड्स अपन द सिचुएसन. त्यस्तो छ भने अर्कोमा चाहिँ लास्टली ल्याटरल टु मिडियल ल्याटरललाई आई राख्ने मिडियललाई आई राख्ने. ठिक छ. यो गइसकेपछि आई भन्दा पनि फर्दर जान्छ जस्तो कि एउटा B3 भयो B3A भयो A को हामीले डिभाइड गर्यो AI भयो AII भयो त्यसको पनि फर्दर गयो भने AI अल्फा आउँछ AI बीटा आउँछ इभन AI गामा आउन सक्छ यसलाई पनि फर्दर गयो भने AI अल्फा X आउन सक्छ झन् सक्छ त्यति धेरै अन्डरस्ट्यान्ड गर्ने त्यो इम्पोर्टेन्स त्यस्तो छैन तर theoretically if somebody asks you how do you classify the bronchitis that you must be able to answer हैन त्यो भएर यसमा यसरी यो पिक्चर यसमा देखाएको चाहिँ quite complicated but you must be able to recognize in a good CT quality you can recognize these all structures also यो डिटेलमा ल किन we will have extra classes regarding how to read the patterns of the in the CT scan how it correlate with the bronchoscopy. So this is the horizontal vertical pattern. Something will be seen horizontally, something will be seen rounded that will not appear in this image. At next section you can visualize that one. Right? So this is the horizontal oblique pattern that we do not define. Our main important as of मेरो क्लासको थियो भने this also definitely कि तिमीले जे चिज तिमीलाई ब्याक चाहिँ हुँदैन. So now let's start the bronchoscopy. Recapitulate. जो हामीले last time गरेको थियो. So what do? We anesthetize the patient, topical analgesia दियो, then we move inside. So this is the CT picture at the level of the larynx. हैन? Oropharyngeal larynx. The first structure will visualize the epiglottis, right? Then pyriform fossa will be both sides. Then the next thing we will visualize whether the vocal cords are moving or not. It is the midline position, adduction, abduction, whatever. It's a parachute or no movement. This is the first thing that you have to capture. Because if there is something not moving, vocal cord, then we must think that patient has got the recurrent adenoid injury or palsy. That will totally take the patient your diagnosis of T4 lesion. So anything not moving, then you can just, on the basis of bronchoscopy, you can say that this is the T4 lesion. So thereafter, as shown in this picture, the left vocal cord is not moving. Then you can guess that this right vocal cord is not moving. Your vocal cord is not moving. It is moved. So it means there is the vocal cord palsy. So it's the same cheese, same mobilize. So then CT scan, as I talked with Dr. Southern, maybe something should be knowing these structures. And this anatomy also you have to remember, cosary segmental division, cosary subsegmental division. This is the next thing also similar in the left side. Now, this is the trachea. Now, after introducing inside the vocal cord, you will visualize the trachea. So, it is about 18 to 22 C-shaped rings. So, when we see interolaterally the cartilage part, posteriorly the cartilage is missing. That is the membranous part. The diameter, male, female, male is wider, 2.5, and the female is 2 cm. Wide is also important. One thing that I never commented in our anesthesia, they do not know which side of the to introduce the double limiter. Actually, they think at the age male say at the size को fit होला, कसैलाई 33 double limiter लाग्ला, कसै 35 लाग्ला, but actually we have to measure on the basis of CT scan. What is the tracheal diameter? It's very easy to measure. Even the radiological chest X-ray measure गर्न सकिन्छ. तर त्यो भन्दा अलि थोरै सानो साइजले भने exactly that is the exact measurement. Which size of the double limit tube you need to insert, right? So this is a roughly category. So one tracheal ring is about 5 to 6 millimeter in height, right? Calculate. So length has been written here. Length 12, 18 centimeter, diameter, etc. Now we'll see this is the seeding. This is the membranous part. Then the next structure that will visualize the carina. Carina should be soft. If it is blunted, that means there is some lymph nodes just beneath the carina, subcarinal lymphadenopathy. So the patient must be having N2 disease at least if you visualize the subcarinal lymph node. I mean the blunting of the carina. So that is called the C1 carina, right? यसको पनि क्याराइनलको नोमेनक्लेचर कस्तो छ त्यो पनि मैले लास्ट टाइम भनेको थिएँ के भन्नाले चाहिँ जस्तो कि हामीले यसरी मुभ गरेका छौं the trachea. So this is the C1 carina, right? Primary. Then it divides from the main and truncus interment. This carina is here, the C2 carina. This much it will divide like further. This is the C3 carina. It will divide like further. This is the C4 carina, right? So हामीले visualize कसरी गर्थे visually नि तपाईले देखिन्छ कुन लेभलमा carina जुन higher छ that comes first. त्यसपछि तल छ that comes next. And त्यसरी segmental division पनि हुन आउँछ त्यसमा पनि त्यही देखाएको छ पिक्चरमा बेसिकली यसमा पनि one of the rare abnormalities is found less than 1% of cases the tracheal bronchus. The trachea and the bronchus is directly arising from the trachea. It should have come lower down, but it's arriving directly from the trachea. This is tracheal bronchus. So here main bronchus ko pani dekhna sakiन्छ. So this is the CT picture where we visualize right main bronchus, left main bronchus. Their structures as labeled here. यहाँ पनि apical right B1 देखाएको छ गोलो, because as I talked before, हैन सबै स्टेज यता apical posterior को interior छ, यता apical posterior को left side मा यो पनि clearly देखिरहेको छ हैन. So now the next question comes, which side do you examine first? So last time also I talked to Southern that you examine that side which is normal in the CT film. The side affected you should examine at the last, right? So this is the D-shaped trachea again. This is how the bronchoscope is moving inside the trachea. Then the C1 carina is seen. Then there comes the C2 carina shown here. C2 carina, right? Then comes the C1 is the primary, C2 is the secondary. The another nomenclature. This is the right main bronchus about 1.5 to 2, sometimes 2.5 in the long patient. This is the Western guidelines, so they have written 2.5 in Nepalese population of 1.5 to 2 centimeter. It's shorter. Then you go rotate in the clockwise direction, 90 degree. Then we'll go to the wrist, the upper lower bronchus right here. Then we'll see the B1, B2, B3. We can see the carina here. Then next carina is here. Next carina is even deeper, right? त्यो अनुसारले हामी उसको सब सेगमेंटल डिभिजन पनि भन्न सक्छौं. Let's suppose this is the B1, this is the B2, and this is the B3. What's happened? B1, B2 is the common trunk because this carina is a little bit deeper than this carina. Okay, C3 यो हो, C4 यो हो, okay नि, C5 त्यसको भित्र छ. भने यो दुईटा कमन ट्रङ्क आएको हो. त्यसैले हामी जज गर्न सक्छौं. भन्नाले जसरी हामीले सोच्छौं नि B1 should be divided into trifurcation. It's wrong. It's not the common variant. के हुन्छ यस यो पोजिसनमा के छ भने B1 and B2 has come together as a common single trunk and B3 as a separate trunk, हैन. त्यो हुँदाखेरि यसको लेभल कसरी जस्टिफाई गरेको दिस carina a little lying deeper, not at the same level lie भएको सबै carina भनेको trifurcation भन्न मिल्थ्यो. So this is the same thing like Mercedes Benz you can see, हैन, B1, B2, B3, right? You clear छ हैन, B1, B2. So this pictorial diagram you should keep in your mind. So when you do the bronchoscopy, this thing you will visualize, right? But it's not always fair. किनभने जहिले पनि त्यस्तै डिभिजन हुन्छ भन्ने छैन. कहिलेकाहीँ यता C4 जुन मैले अघि भने C3 यो C4 यसको भित्र छ, हैन. This will depend कि हाम्रो सब सेगमेन्टल डिभिजन कहाँनिर पुगेको छ, के पुगेको छ, यो पिक्चोरल डायग्रामले हामीले बताउँछ, हैन. यसरी C3 C4 भयो. Again, right? यसमा के भएको छ यसमा भन त कस्तो उ होला सन्दीप, कस्तो कन्फिगरेसन होला B1 B2 B3 को
यतापट्टि सर
B1 single,
B1 चाहिँ एज अ सिंगल सुटअप भएको छ, B2 चाहिँ B3 कमन.
बुझ्यो सक्दैन हैन भेरिएन्ट हैन, ट्राइफर्केसन हैन यसको, बाइफर्केसन छ, बाइपेरियड भेरिएन्ट छ यसको. Similarly, you have to look into the CT scan. This is the rounded structure. This is the B1. ठीक छ. हेर यो चाहिँ B2 र B3 छ. ठ्याक्क तिमीले जस्ट चाहिँ CT scan र ब्रोन्कोस्कोपीमा गर्नुपर्छ हो. So the pattern of the branching pattern right upper lobe bronchus, as we think this should be trifurcation, is not common. People separate B1, B2, B3 आउनुपर्ने common हैन. Generally it's bifurcation, simple bifurcation like B1 plus 2 र B3 यसरी आउँछ. सर आउनुभयो तिम्रो? बाइसक्नु ल ठिक छ. यो गरेर आज क्लास सकाइदिन्छु हैन. So there may be several types also, split biopsy etc. भने चाहिँ हाम्रो यसबाट आजकोबाट चाहिँ हामीले के बुझ्यो, अझै पनि we have to do a lot of another classes हैन. Lack of time, they will next time say take a time now, okay? So we can have the theoretical aspects more. And I wanted something to also to present, and it's essential for him also. So these are the pattern. Is not trifurcation is not common. Another variants may be common. So we'll discuss later on regarding this. Thank you.